some years ago regarding medications because too many patients were having adverse reactions or actually losing their life because of we weren't paying enough attention to how we administer meds. You know, we were falling behind on how your allergies are documented, so patients could be getting things that they are allergic to. The look-alike, sound-alike drugs. So, you know, the Joint Commission has decided that, you know, there has to be a way to distinguish between those two medications. They look alike, they sound alike, and you have to be able to distinguish between which one you're supposed to give. Some of the packaging on medicines that looked alike and sounded alike, they were made by the same company. And so, when I'm in a hurry, if it's in the gray package with the purple lettering on it, and that's what I'm looking for, but both of those are in gray packages with purple lettering on it. So you have to stop and take time to look at the package and make sure that what you think you're giving is what you're giving. There are 5 rights to medications. You have the right patient, it's the right time, the right medicine, the right dosage, the right route. And you have to determine all of that before you ever give that patient the medicine, because once you give it, you can't get it back. So it's best to err on the side of caution, to be very cautious when you give medicines. When I have worked at the bedside, there was a patient, and I can't remember what the medication was, but we were having some issues with her medicine. And she was frustrated, and I knew that she was, but my point to her was, I'm going to make very sure that what I'm giving you is what you're supposed to have. So I've got to give me a minute to get with the pharmacist and make sure that everything you're supposed to have, I give you. I didn't want to give her anything because there was a discrepancy. And as long as that discrepancy was there, I was not going to give her anything until I was totally clear in my mind what she was supposed to have, when she was supposed to have it, and that kind of thing. But we're going to talk about abbreviations and symbols of measure. Now, one thing I will say about the abbreviations, that's just something that you're going to have to memorize. It's like when I was in elementary school so many years ago, we just learned multiplication tables by memory. 3 times 1 is 3. So we just learned it by memory. And with your abbreviations, that's what you're going to have to do. You're just going to have to memorize those things. And I'm looking at one of your lists that has a list of the abbreviations. It's in your textbook. It has the abbreviation, and then it has the meaning. And you just have to memorize this. A lot of these abbreviations are based on Latin, so they don't make sense to us. But like the letter A, and it's usually, is there okay, yeah, the letter A, and it's usually got a hash mark on the top of it. A means before. AC means before meals. AD means right ear. AM, of course, means morning. AS means left ear. It goes on and on and on, lots of abbreviations. But you just have to memorize them. There's no other way around it. There's not anything that I can tell you other than you just simply have to memorize it. And the more you work with it, the more familiar you'll get with it. One of the things that we did when I was in nursing school is that we would either write the symbol and then have a line across for where we had to fill in the blank of what write the abbreviation, then have a line across, and then we wrote the meaning, or we had the meaning and then we had to write the symbol. And we did that back and forth for several weeks, me and my suite mates, so that we could become very familiar with it. One of the things that I will caution you on is physician handwriting, and that's one of the reasons why most people or most companies have gone to electronic medical record. Because physicians' handwriting is usually so awful and not clear, that most times you're trying to figure out what the physician has written. Thank you. You're trying to figure out what the physician has written, and that should never be the case. It should be clear enough that you understand it. So I'm going to show you an example. This means milligrams. Standard dosage. That's a standard dosage for medication. But what if the physician's handwriting is awful and he writes this? Now, what is that, milligrams? Is it there's MEQ, that's milliequivalents. There's micrograms, which is MCQ. So which one is the physician? Which one does he mean for you to give? And it's never designed for you to figure that out. You just have to ask for clarification. Or, since so many facilities are going to the electronic record, it's much clearer. You don't have to try to figure out what the physician is writing, or the nurse practitioner, or the physician's assistant, who's ever responsible for writing orders or prescribing medications. So you have to be careful that that you know the abbreviations. Again, that's just something that you're going to have to memorize. You know those abbreviations, but if it's unclear, you do have to stop and ask for clarification. Most places are using electronic medical records. I believe there is a financial benefit in it for the hospitals if they got their electronic system up by a certain date. For acute care hospitals had a date, then long-term care hospitals have a date, rehab hospitals have a date. I think doctors' offices also have a date. But it is it's more convenient. You don't have to guess about what does the physician mean, what is he writing. It's much clearer. But again, with the symbols and abbreviations, you simply have to learn it, and it's just a series of memorization. And it can be confusing, especially with symbols that you don't use a lot. I guess if you worked in the eye doctor's office, you would see OD and those kinds of things for the eyes, right eye, left eye. But if you don't work in a general clinic or something like that, you may not see that as much. So just familiarize yourself with that. Work with it, memorize it, write it down, write down the abbreviation, write down the meaning, write down the meaning, then write down the abbreviation. And if you can do that several times, now there are going to be some symbols and abbreviations that you run across that you may not have seen before. There are some general abbreviations, then there are facility-specific abbreviations. Some facilities have their own abbreviations that they use, and you may work somewhere and you may have to ask for clarification on that. But the ones that are used most times, you need to make yourself real familiar with that. Now, the systems of measure, how we measure medication, it is so crucial that the system of measure is right, and how we measure and administer medication. Now, all of the medications mostly are written. If you're in a facility, if you're in a doctor's office, they're written using the metric system, using milligrams, milliliters, liters, grams, milligrams, micrograms. But if the doctor is writing a prescription, or he is giving, or you are giving instruction to someone on how to give medication at home, then you use a household system. You don't want to say, the household system is like teaspoons, tablespoons, those kinds of things. And medications are translated into those measures for people who are administering medicines at home. Children, a lot of time, the doctors will give a teaspoon of this, and so that's for the person who's giving medicine at home who has no medical knowledge, because you don't want to write milligrams or milliliters. because most people don't have access to something that measures milliliters, but they do have a medicine cup that measures teaspoons, or they have a measuring spoon, a teaspoon measurer at home. So it's not as accurate as a metric system, but it is appropriate for people who are non-healthcare providers, and especially if you're giving medicines, a non-healthcare provider, you want to make it as simple as possible. You want to use symbols and measures that the people are familiar with. The medications are measured two ways: solids and liquids. And the solids is pills and those kind of things, suppositories. Liquids, of course, is just what we said, liquids, and it can be suspensions, which are liquid out, but they're thick liquids. Now, the metric system, it's measured in units of 1,000. So, 1 gram would be equal to 1,000 milligrams. So, 1 gram equals 1,000 milligrams, and vice versa. 1,000 milligrams equals 1 gram. And just have to be familiar with that, because that is the standard unit of measure. Most medications are in milligrams. There are a few medicines that are in milliequivalents. There are a few medicines that are in micrograms, but those are few medicines. Most of them are in the unit measure of milligrams. And you can convert the dosages back and forth however you need to, and I'll just be honest with you, math and this is not my strong suit. So, and especially since I've not been at the bedside much frequently, I'm going to just write this down. So 1 gram equals 1,000 milligrams, and in 1/10 of a gram equals 100 milligrams. And this is 1/1000th of a gram equals 1 milligram. It's all in ones, tens, hundred thousands. So 1/1000th of a gram equals 1 milligram. It's just a matter of moving the decimal to get the calculation. Liter, 1 liter is 1,000 milliliters. Milliliters, and a half of a liter, 0.5 liters equals 500 milliliters. 1/10 of a liter equals 100 milliliters. 1/10 of this is 100 milliliters. So it's just a matter of moving the decimal and just being aware. That's the measurement. Any IV fluids is measured in liters or milliliters. So you want to just make sure you're familiar with that. I would learn the metric conversion chart just by, again, it's memory, learning how to move your decimal point, but being aware that in a facility you're not going to see, to give a patient 500 teaspoons of something. It'll be 500 milliliters of a solution. And y'all stop me if you have any questions. Again, the household system is just where you, what you use at home when you are administering medicines, maybe to an elderly parent or to your child. A teaspoon is 5 milliliters. A tablespoon is 15 milliliters. 1 ounce is 30 milliliters. So if the doctor wants to give a child 5 milliliters of a medicine, he would order a teaspoon. That would the prescription would say 1 teaspoon of such and so. One of the things that when one of my daughters was small, a baby, can't remember exactly what was wrong with her, but the doctor was prescribing a medicine, and he said, because I was a nurse and I had access to a syringe, I could pull up 2 cc's or whatever the doctor was ordering. And he said, make sure that the pharmacist does not order you 2 teaspoons of this. I want your child to have 2 milliliters of this. And so, but when the pharmacist, when he gave it to me and he had filled it, even though I told the technician, now the doctor specifically wants 2 milliliters of this, not 2 teaspoons, and she said, okay, but the way the label read was to give 2 teaspoons. And so, because I had already discussed that with the physician, I knew that that was not right. So they just took the label off and redid it. But one of the things that you have to be careful about is that whatever medications you're taking, that the pharmacy dispenses it the way the physician has written it. And if there's any question, it's the pharmacist's responsibility to get clarification for that. Just like I said, it's not your responsibility to guess about what the physician wrote. It's not the pharmacist's responsibility to guess about what the physician meant with a prescription. One of the things about medication administration is that patients are going to get medicines if they don't get anything else. So we have to be on top of our game, knowing what the medicines are, if it's appropriate for the patient. One of the experiences that I had, and I think Miss Alicia may have addressed this, was when you're giving medicines to the elderly and the people who have certain disease processes. They may be have overweight, they may be underweight, a lot of fat, not a lot of fat, but more fat storage and that kind of thing. But one thing about the elderly is that medications, if you give them a medicine to sedate them, a lot of times they have the opposite reaction and it makes them very agitated. So now the patient is extremely agitated. And what I have found, and there is some evidence to this, research evidence, is that you give the patient the elderly, the smallest dose possible. Now, if you need to give additional, you can add more to it, but you start off with the smallest dose, and you generally will have the result that you're looking for. The patient's agitated, and you're trying to calm them down. Giving them a large dose of medication sometimes will make them extremely agitated. I had a patient who was had this major surgery. She was 90 years old at least. I can't remember exactly, but she was old, 90 or 95, and she had oral cancer. And it got to the point where she could not swallow. She refused any treatment, any radiation, no chemotherapy, but it got to the point that she couldn't swallow. So they went in to remove the tumors, and she had to have this radical surgery. She came from surgery with a breathing tube in her neck. And she was my patient. I worked in ICU, and I kept asking, are you hurting? Are you hurting? And she said no. And when I interviewed her family was like, she takes no medicine. She made, the strongest thing she's ever had is an aspirin. So I was very hesitant to give her any pain medicine. Not that I wouldn't have given it, but I would start at a very small, even though the doctor had written for a pretty significant dose, I would have started at a small dose and worked my way up to the dose that now that's probably, I think they would call that ordering medicine or prescribing medicine. But for my patient's well-being, I'm not going to go in and give her that total dosage. Well, I'm going to tell you what happened is she had nothing for pain since she got back from surgery, which had probably been 3 or 4 hours. And I took a break, and I told my nurse who was in the same area with me, don't give her anything for pain. If she needs something for pain, let me know, and I'll give it to her. And so something happened, and she went in the room, and when she saw all that reconstruction surgery, this is the nurse who's working in the same area with me, she just knew this woman had to be hurting, and so she went in and gave her the entire dose, and she stopped breathing. The patient stopped breathing. So you have to be aware that the elderly cannot tolerate those large doses like that. You're not going to get the result that you're looking for. So just be aware of that. And not just the elderly, but people have major reactions to medicines that may not be common. Each medicine is going to affect everyone differently. Now, when they do the studies and the clinical trials and all of that, you have side effects, general side effects that lots of people will experience. But if you read the research, they'll talk about, one person may have reacted this way, one person had a reaction this way. So no two people are ever going to react to a medicine the same way. So you have to keep that in mind when you're dispensing medicines. So we want to be very sure of what we're giving. We want to understand the metric system and how we convert one dosage to the other. We go from a larger dose to a smaller dose, or a smaller dose to a larger dose. And it's just done on a series of 1,000s. Okay? Y'all got any questions so far? No? Okay. And I like to put my little real world stories in there because